Hi, I'm Dr. Marty Weiser. I am a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center. My interest and expertise is in intestinal cancers, including colon, rectum, small bowel, and appendix. What are the challenges of operating on the rectum after radiation, and are there differences between short course radiation and long course radiation? The radiation effects can be classified as early, intermediate, and late. The late effects include fibrosis, and classical surgical teaching was that rectal resection should be performed within 6 weeks of the completion of radiation to allow for response, but not the development of pelvic fibrosis that could make surgery more difficult. As the popularity of non-operative management of rectal cancer grew, we began to question the need to operate at that 6-week mark. Since tumor response to radiation occurs over many months, waiting would likely increase the proportion of patients that would be candidates for rectal preservation. We know from retrospective studies that the effect of radiation continues over 12 to 15 weeks following completion of treatment. The timing of rectal cancer response to chemoradiation trial was a phase 2 multi-institutional trial that asked the question, can you wait a longer period of time following chemoradiation to allow for response? And does this increase complications or morbidity? During the waiting period, successive cycles of FOLFOX chemotherapy were delivered. There were 4 groups in the study, each containing 60 to 70 patients. The time from completion of chemoradiation to surgery varied from 8 weeks in group 1 to 19 weeks in group 4. And therefore, patients received no consolidation FOLFOX and up to 6 cycles of consolidation FOLFOX. So surgery was either at 6 weeks or 6 months following completion of chemoradiation. Now, surgeons were asked about the degree of pelvic fibrosis and the technical difficulty of surgery. And although in these questionnaires, the degree of fibrosis was slightly higher in groups 2, 3, and 4, that is those with a delay, this did not increase the technical difficulty of surgery. And the estimated blood loss and the rate of complications were similar between all groups, indicating that the delay was safe. Interestingly, the complete pathologic response rate was 18% in group 1 with no delay and 38% in group 4 with the 6-month delay and 6 cycles of FOLFOX chemotherapy. It's unclear if this increased response is due to time or consolidation chemotherapy, since both factors were changed in the trial. Now, what about short course radiation? The Stockholm 3 trial asked the question, can you delay after short course radiation? So this 3-arm trial compared short course radiation and immediate surgery versus short course radiation with a 4 to 6 week delay compared to long course chemoradiation with a 4 to 6 week delay. Now, if we first look at the short course radiation versus short course radiation with delay, there was increased overall complication and surgical complication in the short course with immediate surgery. Total complications were 53% versus 41%, surgical complications 36% versus 28%. Now, if we dive into the short course radiation with immediate surgery a little bit more closely, we see that the group that had the greatest complications were those patients that had surgery 2 weeks following the completion of short course radiation. The patients that fared the best had surgery 1 week following chemoradiation. Now, if we compare the short course radiation with delay to the long course chemoradiation with delay, those groups had similar rates of overall complications and overall rates of surgical complications. And I think the Stockholm 3 trial teaches us that short course radiation with surgical delay is safe and similar to long course radiation. If you're going to have short course radiation and immediate surgery, the surgery should be within a week. Most recently at ASCO 2020, the Rapido trial was presented. This is a trial of very bulky tumors that either had T4 disease and N2 disease, lateral node involvement, at-risk mesorectal fascia, or extramural vascular invasion. Patients were randomized to short course radiation with consolidation FOLFOX-CAPOX, followed by surgery. This was compared to chemoradiation, surgery, and adjuvant chemotherapy. The main results of the trial showed reduced disease-related treatment failure and reduced 3-year distant metastases rate in the total neoadjuvant therapy cohorts. But they also looked at complications. The TNT was short course radiation, that is the short course radiation with delay, and the long course chemoradiation had similar length of stay, readmission, all surgical complication, as well as grade 4 and 5 complication, same rates of reoperation and anastomotic leak. So I think we can take this data to say that surgery following chemoradiation with delay is safe. This allows for a more complete response, and there's no increased complications.